Hello, everyone. This is Dr. Susan Hudson from Texas Fertility Center with another episode of Fertility Docs Uncensored. I am here with my sensational, splendiferous co-host, Dr. Carrie Bedient from Fertility Center of Las Vegas,
Hey.
and Dr. Abby Eblen from Nashville Fertility Center.
Hey,
How are you guys doing?
Good.
doing
How are
great.
you?
Good. It's crazy hot. It's the middle of summer.
It is crazy
Oh,
hot.
yes. Oh my God, yes.
I have a black interior in my car. Woo, it's hot.
Mhm.
I like to turn my car on and let it cool off.
I forget to do that until I get in the car and I'm like, why didn't I turn my car on?
Mhm.
It's a good thing. It's a good thing. So what are your favorite like frozen treats during the summer?
Yes.
Yeah.
I'm sorry. Was that not the answer you were looking for?
I was looking for it a little bit more narrowed down than to like all.
Oh, well, why would you narrow it down from all when all is one of the options for frozen treats?
I just not what I was thinking.
So I guess there's multiple categories that this can fall into because there's the frozen treats that you can keep in your own freezer, and there's the frozen treats you have to search out. And so
Mm.
for the frozen treats that can be kept in my own freezer, and I think we've talked about this before actually, the Malona melon popsicles,
We have talked about that, yeah.
they're
And
absolutely my favorites. And the coconut ones are very close behind with the mango ones. And so I have a full box
you
right
can
now.
buy those in the store or you have to get
I
them
found them in
somewhere.
Costco. You can also find them in like the Korean Asian markets. It's a Korean
Malona?
thing.
Malona?
Malona. hmm
Malona.
And so
Okay.
I may or may not hide it in the deep freezer from prying little hands and mouths and tummies. But those are my favorite ones to keep in the house. What about you
What are
guys?
okay, now I'm intrigued as to the things that are outside of your house.
Yeah. Well, maybe like slushies or something like you can't really make a slushy real well or
So
frozen
yes, you
margarita.
you can't do oh no, I've got a good blender for that. I've got that all taken care of. There's all the custard type places that are around here where
Oh,
it's
frozen custard.
homemade custard where like I
Huh.
make ice cream, but it's kind of a pain in the neck and it takes a while and you have to clean it and you have to clean the
Yeah.
machine and blah 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 blah.
Yeah.
Ice cream that other people make that's better than what you can buy in the grocery store, like Handles is a brand around here that I love. So that's really good. The other thing is there's a Mexican dessert that it's like shaved ice and ice cream. You sometimes see it in Hawaii too. And it's kind of a
Oh yeah.
combination between
Yeah.
snow cones and ice cream. And
Oh, I know what
I
you're
have,
talking about. That is
yeah.
yummy.
It is. And I don't think I've ever tried to do it at home just because you can't get the ice like that. You can't get the syrup that's just perfect. You can't find the marriage of the syrup flavor with the ice cream flavor. Like this is like they're artists, don't screw with a good thing. So, and it's usually best if you find it on one of the street corners.
Mm. So Abby, what's your fave?
So Jenny's ice cream is a local brand around
Yes.
here. I think it's local
Yes.
around here, maybe, but brown butter and almond brittle, that's pretty excellent. If I'm going to waste my calories, I want to waste them on something good. That's really good. And there's also this lavender one that I had to look up. It's called Wild Berry Lavender, and it's got brambleberry ice cream with a pop of sweet orange and lavender. That's a good one too. So
Very
she always
cool.
has some really interesting mixes of things.
hmm
So,
hmm
I like chocolate peanut butter frozen bananas.
oh,
Oh,
that sounds good. That's
They're
I'd go for that.
amazing.
do you know that Reese's just started making those you can buy in the freezer case? I just saw them
Oh,
yesterday.
the ones that I get they're made by a company called Diana's, and
Oh.
I have to say, like we all like shuffle them around amongst. I have a few refrigerators and freezers at my house, and so like we all in our house will go and like put them in secret places so that the other people can't eat them.
Okay, so it's like a banana that's like dipped in chocolate and wrapped in peanut butter, kind
No,
of,
no,
or
so it's a banana on a stick, and then it's
okay,
dipped in peanut, like it's covered in peanut butter, and then it
okay.
has chocolate on top of it. And then you leave it when you take it out of the freezer. You leave it out for like 10 to 15 minutes, unless you have like invincible teeth. And then
Oh,
it's melted just
Gooey.
enough that you can
Yeah.
bite it and it not fall apart on you, and it's all like, oh.
You know, Susan, I'll have to say, knowing you now as well as I do with all of your food allergies, I'm actually kind of shocked that peanuts is not something you're allergic to,
Me too. I was
obviously.
just thinking about that
Thank
because I saw that
goodness.
and I thought about you in the store and I'm like, oh, she can't eat peanuts.
She can't eat that.
Oh, yeah. No, I like
Huh.
nuts. The only nuts I avoid are pine nuts and pistachios.
Ah,
So
I feel like, okay, I'm putting this into the universe. So, Jenny's, if you want to sponsor us, Diana's, if you want to sponsor us, Handles, if you or Malona, if you
yeah.
want to sponsor us, we always appreciate the things that allow us to keep this podcast free. And so, if any of those big
as a
companies
dessert, work.
want to sponsor us for dessert,
We
we will
love that.
happily put you on for ads in this podcast. And I personally will help sample all of your products in order to make sure we can give a really genuine
So we can
um,
compare and contrast each of our selections.
yeah,
Yes.
yeah. I mean, we're pretty picky about who we let on, but you know, I am
We'll
willing to go the
we'll work
distance.
for dessert.
Yeah,
We'll
we'll
work
work
for
with it. Yeah.
100%.
Yes.
All right, let's do a question real quick. Okay. Hi, doctors. Thank you so much for the podcast. It's been an immense source of help for me as I've been going through IVF this year. Thank you for listening. She's 32, husband's 34, unexplained infertility, been trying for 2 years and 3 chemical pregnancies. Went through IVF, had 42 eggs, 36
Wow.
mature, 28 fertilized, and had 15 blasts with 8
Wow.
PGT normal embryos. No complaints, and feel that they're very lucky. But the
Yeah.
question is about her AMH. Her AMH has been tested twice. The first time it was 2.2 and the other time it was 2.8. I feel like the AMH is low given how many eggs were retrieved. Is there an underlying issue that could cause this discrepancy? My RPL panel came back normal. My FSH is 8.8. Everything else has been normal. Thank you.
Who cares what your AMH is? You got 42 eggs. It's awesome. I mean, you know, you're the type of person that all of our other patients look to and go, gosh, that person got 8 normal blastocysts. Why didn't I get 8 normal blastocysts? Well, that's because you're in the 99th percentile. I mean, the average woman that goes through doesn't do that well. You know, the AMH is really just a guide. And I do think it's helpful when I'm trying to help determine a dose, at least a starting dose for somebody with IVF. But that's really all it is. I mean, it's just a guesstimate, an estimate, and it's really most helpful when we're trying to determine how many eggs you have. And the time that that's most important is when you're going to do IVF. And so your doctor did a fabulous job of figuring out how to stimulate you well enough that you got 8 normal blastocysts. So don't worry about the AMH. No big deal.
I would also say that not all AMH levels are created equally. It actually is one
Yeah.
of those tests that lab to lab, we can have quite a bit of discrepancy. And so, and that's been an issue with AMH as long as I've known about it being available. I mean, that was actually part of one of the hard things about it kind of breaking through and becoming a mainstay in fertility testing. But I think we tend to get AMH at the same lab. And so we know within our practices what that number means. And that probably is what happened with your situation is your doctor knows what a 2.8 means at your lab, though it would not necessarily be the same at wherever we're getting it tested.
To a degree, it depends on what your antral follicle count was, because you can have people with 2.2 or 2.8 AMH that get 15 eggs, and you can get people who get, like you did, 40 eggs. And so it's a guide. There is not an absolute correlation between if you have this AMH, then your egg quality or your egg response will be that. I mean, there's so much that goes into this that I would not overanalyze that as a cause of anything really.
And
Well,
it's
another
not
thing
a concern going into your embryo transfers.
Yeah.
Exactly. And I would say actually when somebody gets that number of eggs, usually you don't actually do quite that well, which is kind of counterintuitive to what you would think. But your body usually just doesn't make that many eggs well enough that you end up with 8 normal blastocysts. So the quality issue is not an issue for you at all. You have really good quality eggs, so that's great.
Good stuff. Good stuff. All right. So today we are going to talk about literally the first step, your new patient appointment. I know we've done it before, but it's good for us to recover it and bring up new things. So first of all, like when should you call and make that appointment?
Well, it depends a little
Yesterday.
bit. Yeah, yesterday. Depends a little bit on your age, and it depends a little bit on your diagnoses. So if you're, have regular cycles, you think everything's good, and you're under 35, the American Society for Reproductive Medicine recommends that if you've tried for 12 months, and trying means you're not on birth control pills and you're having sex, you could get pregnant. That's trying. If you've done that for a year and you've not gotten pregnant, then that by definition means you need to see a fertility doctor. You have infertility. If you're older, if you're 36 and beyond, you probably need to see your reproductive endocrinologist or fertility doctor within about 6 months of trying. So typically that's the rough guideline, but then there's other things that can make us decide to bring you sooner rather than later. So if you have irregular cycles, that's not going to be corrected in a year. Nothing's going to change there. And so those are people that are probably not ovulating. That's probably the issue. And you need to see either your doctor for sure, gynecologist, or fertility doctor if your gynecologist is not able to help you ovulate. If you have blocked fallopian tubes, that's not going to get better in the next year. Or if your husband has no sperm or really low sperm count, then don't wait, 6 months or a year to see a fertility doctor. See them sooner rather than later. Yesterday, like Carrie said.
One thing I always advise is if you in your heart feel like you need to get checked out, go get checked out. I mean, there's something about intuition, and I don't think there's an REI out there who are like, you're nervous, you want to just make sure everything looks fine. Because if there is something that we need to work on, then we have time to work on it. And also another thing to think about is size of your family. So Carrie, how does size of the family make a difference in those general guidelines that Abby just talked about?
Yeah, so if you are, well, it all depends on how big you want a family. So if you want one kid, then in general, you've got a little bit more leeway when you are 35 or lower, or even in the kind of mid 30s, 36, 37, 38. Like we've got a little bit more wiggle room there. If you know that you want two kids though, or three or four or more, then you have to start thinking not only how old am I going to be for this first child, but how old am I going to be with the second, third, fourth? Because you have to add in the time it takes to get pregnant, to be pregnant, to pop a small child out of your body, to then feed and keep that thing alive, that person, I mean, totally
That
person,
thing.
that thing. You can tell the kind of day I had earlier today in my house. I love them very dearly. I am very grateful and appreciative, but oh my God. So to keep a kid alive and then get through breastfeeding, if that's on your list of things to do, all of those things like that takes a couple of years to do. And even the most motivated people who say, oh no, I'm going to come back 6 months after my vaginal delivery to do this again, you're probably not. And not because you're a bad person in any way, but because this takes a ton of energy and mental space, and the physicality of what you're doing is really quite high, and nobody tells you that. Or they do and you don't realize it. And so if you know you want multiple kids and you're already sitting at 35, well, by the time you get to the second one, you're pushing 40. By the time you get to the third one, you're 42, 43. That all makes an impact. So if you need to get those eggs out now to make embryos so that in 6 years you can be working on your second or third kid, then that plays a large role too. And so we have lots of people who don't necessarily have fertility issues, but they know that they're going to be wanting to have children at ages that start to become a lot more difficult. And so they start to plan ahead for it.
So, okay, I've decided I need to make an appointment. What are some good resources to figure out where are doctors and who might be a good doctor for me?
So I mentioned the American Society for Reproductive Medicine. That society has a website, and it's geared not only just for not just for physicians, but also for patients. And so you can actually go on there and you can look up your state and you can figure out who the doctors are that do this and that are board certified in reproductive medicine. And there's some doctors, OBGYNs, who like to kind of do a little bit in the way of fertility testing and treatment. And there's nothing wrong with that, but it's just kind of important for you to know that, if you need to go to the next level, if you need a more aggressive treatment, then generally at some point you would get to a reproductive medicine specialist, a reproductive endocrinologist. And so if you go onto that website, they can tell you the people who are actually boarded, who've had additional years of training, usually an additional 3 years after an OBGYN residency, specifically in infertility. And so a lot of times those are the people who you need to see if you're really worried that there's some big issue, or if say you've seen your OBGYN and you feel like that just the problem, you continue to not be able to get pregnant, then sooner than rather than later, you probably want to go see a reproductive endocrinologist.
Or you can listen to episode 215, which is how to choose an RPI, which will give a lot more background on that specific part of this question.
So when I call to make that appointment, do I really need to involve my partner if I have one?
Yes.
Why?
Always. Fertility is a team sport. We are one of, if not the only specialty where we treat both parts of a couple. And that couple can be married, they can be not married, they can like each other, they cannot like each other. They can be friends, they can be a relationship that is at its very earliest. Like, we deal with a lot of definitions of what couples are.
We do.
But this is a team sport. Like, you need sperm and you need eggs to make both these things happen, and we need to get those from somewhere. And so your partner needs to be involved. The other thing is that even if you say, well, I'm going to use a donor of whatever, there are a lot of states that have laws, even Nevada, which is a pretty
Tennessee,
very purple
Texas.
state. There are laws that govern what we do. So even though he may not be participating, and this is in particular when you've got women who are using donor sperm, he will need to be involved. There's probably going to be some documentation that he needs to sign in order to acknowledge that he's okay with this based on how child support laws work in any given state. And so know that we may start the evaluation with just you, but it's unlikely that we're going to do much in the way of treatment or anything significant until we've got him involved as well. At least on making sure the documentation is in line so that we know that what we can do is legal.
And
Even
just
if
be prepared. Just be prepared. We ask really probing questions, and sometimes when you first meet a couple in front of you, you're kind of going, okay, I don't think they're married, but and sometimes you just sort of have to ask as a physician, go, hey, so I hate to really push you into a corner here, but I'm just wondering, is this is this going to be a lasting relationship, or did you guys just meet? Because that sort of helps us determine kind of what we need to talk about regarding, do you want to think about doing things like egg freezing, or do you want to, it kind of helps direct kind of how we're going to counsel you.
And this goes for our same-sex couples too, because a lot of times,
Absolutely.
when I see more same-sex females than same-sex males, but I have a lot of time that they both want to have children eventually, and we're dealing with different ages, and we want to make sure that carrier screenings happened on both of them, and
Yeah.
B testing, and there's all this stuff that actually pertains to both of you, even if only one of you is focusing on it right now. And so those are, additional times that having your partner available for that appointment is helpful.
Yeah, and in fact, I think same-sex female couples are a little bit more complicated for me to think about. Okay, like you said, we got to do carrier screening on both of you. We got to check blood types on both of you. We got to check CMV status on both of you. And back to those probing questions, a lot of times I'll always ask same-sex couples, do you both think you may want to carry a pregnancy someday, or is it just going to be one of you, or how's that going to work? And that's pertinent to what we're trying to do in terms of getting you ready to have a healthy child.
And please know, we are asking all these probing questions. We don't care about the answers. So we do care because we need the
answer.
answer.
Know what they are.
Right.
But it doesn't matter what you tell us.
We just need the answer.
Yeah, like we just need to know, because we're just running the list in our brain of, okay, this is the situation, this is what we need to do to make sure that this is working out to the best it can for everybody. And so, when you look at the things that we see with how couples are made up, and who's related to who and who's not related to who, and how many people are in any given relationship, who's giving sperm to who, and how, like, truly, we don't really care. We just want to make sure that what we are doing is legal and safe and is the best thing for you to get pregnant. So just kind of know that we're asking all these nosy questions. And
so I pick up the phone to make that appointment. What is the time frame that I might expect that appointment? Am I going to be able to get in tomorrow?
Generally not. Generally, there's a wait. I would guess the average fertility doctor has a wait of at least a couple of weeks, and maybe 3 or 4 weeks, depending on what kind of appointment you need. it's because so many people have access, which is great, to healthcare and to fertility treatment now more so than ever. Um, the numbers of us have not gone up dramatically, but the numbers of patients that can have the treatment have gone up pretty dramatically. So we wish we didn't have really long waiting times. Believe me, we really wish that. But a lot of times it can be at least 2 weeks, and it may be even longer than that, depending on what area you're in.
So when I call to make that appointment, what are some, when I'm talking to the lady at the front desk, what kinds of information is that person going to ask?
Insurance card, all of your demographics, so age and birthday and where do you live and all of those things. They usually ask, have you had any testing done? Mostly so that everybody can start gathering it. And I will say that even if you've had testing already done, unless you were bringing in, carrying it in your hot little hands, there is a very high likelihood that we will not have it in our hot little hands when you show up, which does not say anything bad about your OBGYN staff, the lab staff, the imaging center staff, or our staff. It's just, I swear there are goblins that live in these fax machines that eat up people's records. And so I've had people upload them themselves and they disappear. So if you have records, start to gather those, or send them in and sign release
Bring them
records.
in or send them in yourself if you can.
Yeah.
So I'm assuming most states are like Texas. There's a certain amount of time that they legally have until they have to send that information, and it's usually about a month. And so if you're getting in sooner than that, there's a very real likelihood. And quite honestly, sometimes it's easier to get records from across the world than from down the street.
Yeah,
Yes.
sometimes it is.
And
Yeah, if
so,
you can go physically pick them up, sometimes that works a lot better.
I mean, I hate to say this, especially if you've already gotten care at another fertility center. Sometimes yes, they legally have to share that information, but sometimes they're a little slow on the process to getting things over. So the more you can help facilitate that, the better.
Well,
So
and I always feel bad when people don't have their records, because sometimes people can get really bent out of shape and upset. Like, well, I told them to send the records. I can't believe you don't have them here. They get really upset, and it just kind of, honestly, it's helpful to have the records, but most of what we need to know we can get from you. So it shouldn't wreck your day or anything if they didn't send records. We'll get them eventually. It's not a big deal. But it's nice to have them eventually, but we don't necessarily have to have them at the moment we see you.
good stuff. Good stuff. So I make an appointment. That appointment can often be either in person or via telemedicine, depending on what your doctor offers. Different doctors are going to offer different things. And I come in, and what's going to happen when I get to the office? Do they just stick me in a room?
So when you get to the office, this varies by practice. So it kind of depends. So some offices are going to do telemedicine. Some, when you actually get there, will do everything all on that first day, and it kind of varies. So for example, at our clinic, we're doing primarily all of the talking ahead of time. And then when you actually come into the office, you're getting your physical exam, you're getting labs drawn, you may be getting your ultrasounds, things like that. So I actually don't ever see people when they hit the office until
let's talk about the talking stuff. What are some
stuff.
of the what are some of the basic things that we're going to talk about? We talked about probing questions, but what are some of the basics?
So health history questions. So, what medical issues do you have? And if you think it might be a medical issue, it probably is. So tell us about it. So like, because sometimes I'll look through the records and I'll see, oh, this person's on lisinopril, which is a medicine for blood pressure. I'm like, but they don't mention that they have blood pressure. So, so things like that are actually really important. And that medicine specifically is a medicine that we would want to try and have your primary care doctor switch to something different, because it can cause malformations in the baby if you stay on it during pregnancy. So
even if it's been a problem in the past, I don't know how many cancer patients I've seen, and the way I figure it out is they've had surgery, and I'm like, why did you have this surgery? Oh, I had blank cancer. And it's like, that's an important thing. And just because it's not reproductive history doesn't mean it's meaningless to us. We want to know more than less.
Yeah, and another good example of that is sort of along the same line. It'll be like, well, why did you? So they'll be on like an aspirin. I'll be like, well, why do you take aspirin? oh, well, a few years ago I had to go on, this blood thinner. Well, why'd you have to go on the blood thinner? Oh, well, I had a clot in my leg, or I had a pulmonary embolus. Those are important because when you get pregnant, that can increase your chance of having those types of things. So any medical condition that you've really, I would say, that have ever taken medicine for or ever seen a doctor routinely for, you probably need to bring those up because they may not relate, but yet they may relate and you just don't understand how they do. And it may be really important for us to know those. So medical conditions is one. What's something else, Carrie?
So all of the other standard ones, medical history, surgical history, allergies, those types of things, substances that you're using, anything that's containing nicotine, anything of drugs, legal or illegal, alcohol, we want to know about all of that. Again, we're not going to judge, but it's relevant. Even marijuana use, yes, it is legal in the vast majority of places, but
Yeah, that's a big one that people don't leave out a lot of times.
yeah, and some of the scariest moments I've had in the operating room are when people didn't tell me that they were marijuana smokers, and so we didn't know that, and we found out once she started coughing pretty heavily under anesthesia, and it was a very unpleasant time to learn that.
Mhm.
Um, and so all of those questions, and then we start to get really nosy. How many people have you had sex with? When do you have sex? Do you ovulate? Do you pee on a stick? Have you ever had chlamydia? Have you ever had gonorrhea? Have you ever had syphilis, HIV, hepatitis, or
Do you
anything
have
else?
periods?
Do you have periods? Are they heavy? Are they light? Do you have fibroids? Do you have adenomyosis? Do they hurt? Do they
Pain.
not hurt? All of those things. Does sex hurt? All of those things are fair game for the questions that we ask. Oh, and by the way, we're going to ask the male partner, do you get erections? Do you have any difficulty getting an erection or ejaculating? Have you ever had any of this long list of infections? Any damage to penis, testicles, or scrotum? Have you been on testosterone? Should you have been on testosterone? Like, we just go on and on and on.
The answer is
And
generally no to that one.
yes, you should not be on testosterone because it's going to knock out your sperm, and no, thank you, do it later. We got other stuff we can offer.
And I'd give you a little piece of advice too. I mean, if things have happened in your past that you don't want your partner to know about, it makes it really difficult for us if you put us in the position where you say, well, I want to tell you this, but I haven't told my partner this. And certainly we'll honor your request, but it always makes me feel like I'm afraid if I know something about you that your partner doesn't, then I might let it slip or something. So ideally, it would be nice if you didn't keep secrets with your partner, if you were honest about, people are a lot of times really embarrassed if they've had abortions, if they've had sexually transmitted diseases, if they had,
Yeah.
other issues they don't want to share with their partner. It just, it can, we can do it, but it just makes it a little more challenging for us to be really careful. And then we're kind of dancing around, afraid that we're going to ask you a question that maybe some other question that he doesn't know something about. So, or she or whoever. So,
So Carrie, can you address when somebody comes in for that new patient appointment, one thing that we're going to have both patients, both partners, if there is a partner, sign is an information a permission to share information. Why is this type of document needed, and why is it especially important in fertility care?
So fertility is a team sport. This is the only specialty where we're dealing with both halves of the couple. And so your medical records are intertwined. And that is something that it's a good thing. I mean, we can't super effectively treat you when you have to go to two completely separate charts. And so, for example, our charting system, it's built in, like, if it's in one color versus another color, it's the patient versus the partner, but they're both tied together. So if we print off those records, it is to both of those people, and separating that is exceedingly difficult. And when we're going through, oftentimes, let's say one partner is having a procedure and they're under anesthesia. Well, the routine is to talk to whoever they designate, which is usually their partner. And so sometimes there are things that come out during those discussions that, if there are secrets that are being kept, can have an impact. Not usually, but you never know. And so these two charts are very closely tied together. We are oftentimes calling with information that needs to be received, heard, and acted upon in real time. And so if we can't get a hold of one person, we'll call the other one, because we want to make sure that what you're going through is going to be as effective as possible and you get that information. And so it is very much a team sport.
I mean, it's so simple. It's as simple as when you go in for, you're going to have an IUI or intrauterine insemination.
Mhm.
So say he did not sign off on his information to be released. I can't tell her whether or not the sperm looks good. Like, that's just crazy. I mean,
Yeah.
I know it happens, and we always, I mean, if somebody feels so strongly about it, in a lot of those situations, I pretty much insist both of them be there because I don't think I'm adequately practicing medicine if I can't even say, hey, sperm look great today, or not so great, but let's see what we can do. You know, we only need one good one. You know, what do we need to go from there? And so it really does kind of tie our hands behind our back sometimes when you do that. And I understand that everybody has their right to privacy and those types of things, but we're talking about making a baby here. So when we're kind of making sure you really understand what these mean, if you say that no, you can't share information, just understand where we're coming from as well. Okay,
Mhm.
so we did all the talking stuff. And then what is some of the initial testing that may get ordered?
So there, people think a lot of times that we have just bazillions of tests, and we really don't. There's kind of a few basic things that I think we all do, and I'm sure there's tweaks. Different people do a little bit different things, but as a general rule, we want to make sure that he has sperm. So we want to do a semen analysis on him at some point. We want to make sure that you have eggs, and so we can look with ultrasound to do an antral follicle count or look for kind of like baby eggs in your ovaries. And the more that you have, the better. We also can check your AMH, which is a blood test that stands for anti-Mullerian hormone. That gives us some sense that you're kind of where you need to be on the reproductive spectrum, kind of based on your age. So we do some other blood tests, and everybody varies a little bit in these, but we generally do your thyroid. We sometimes we'll check for thyroid antibodies. We do carrier screening testing that looks to see if you guys carry a genetic condition that could be transmitted to the child if you both carry that. It's a blood test. So all these are blood tests that we do. And then the other important test for women is a uterine assessment and a tubal assessment. And generally, those are done at the same time. They can either be done with an ultrasound test or they can be done with an x ray. But the general idea is we put some sort of fluid, either radio opaque dye or we put saline up inside your uterine cavity. It's like blowing air into a balloon. It kind of opens the cavity up, and we can see if there's lumpy, bumpy things there like polyps or fibroids. We also can put fluid through your fallopian tubes and make sure that your fallopian tubes are open. Or if you have one that's blocked, we'll know, which one is blocked. So those are kind of the basic assessments that we do. And I think it varies a little bit in terms of testing that people do blood wise, but those are generally I would say the bare bones basic testing that we would want to do.
So, Carrie, oftentimes at my new patient appointments, really it's the talking part, and we do the ultrasound, and then we get into the testing. Sometimes it's that day, sometimes it's later, but oftentimes we have people who don't understand why we want to do that ultrasound. What is the purpose of that ultrasound? And if my OB-GYN just did an ultrasound, do I really need to have another one?
Yep, afraid so. And the purpose of that ultrasound is to get lay of the land. And so we're looking at the uterus, we're looking at the lining of the uterus, we're looking for fibroids, for adenomyosis, for anything particularly abnormal about size, shape, position, things like that. Most of the time, that tends to be pretty normal or not relevant to the fertility component of this. But we're also looking at the ovaries. We're making sure that we can see both of them. We're making sure that both of them are potentially accessible for whatever kind of treatment we might need to do in the future. We're looking at the number of follicles or very, very early eggs that are visible there. That helps us to give you ideas about success rates. And is your testing high, low, normal for your age, for favorable for fertility purposes, not favorable? And a lot of that information is not recorded when an OBGYN is ordering that ultrasound, in part because when you're at a fertility office, all those ultrasonographers have been trained in how to look for the follicle counts. And those are not necessarily easy to get. They're not necessarily intuitive. And so most of the time when we get a report from somewhere else, it'll say multiple follicles seen
Mhm.
or no follicles seen. And that's about it. Well, multiple follicles can refer to 3 and it can refer to 30. And there is a
Those mean
very
very
different
different things.
fertility.
Difference.
There's a huge difference between those. And so the actual number makes a big difference in what we do and what we're telling you. And so we're looking for all of that. And the day of the cycle makes a big difference too. If you're early on in your cycle, typically day 2, 3, 4, sometimes 5, we get a clear view of that. And it's very difficult to say, to tell somebody who's not in a fertility office, okay, go get this done on day 3 of your cycle, because if you've ever tried to get a radiology appointment on a dime, it just doesn't work. Whereas we're built for people to call us on a Tuesday and we see them on Thursday, no questions asked, they get in, test gets done, and everybody keeps going. And so the timing components of our ultrasounds are also very relevant, and why we want you to do them here with us as opposed to with your OBGYN, because that timing makes a difference in the accuracy of what we're looking at.
And one thing I would add to that too is ultrasound is one of those things that is really dependent upon the person that does the ultrasound.
Mhm.
It's a difficult skill to learn. And even ultrasonographers who maybe do a lot of general scans on gallbladders and livers and hearts and other things, sure, they know how to do an ultrasound to measure the uterus and look at the ovaries. But generally, in our offices, we have ultrasonographers who do like 30, 40 scans in a day, and that's all they do all day long, or GYN or gynecology scans. And so they're a lot more apt to pick up subtle things that maybe would be missed by another ultrasonographer that just does random ultrasounds and, occasionally does a GYN scan. So it's very user dependent.
So, one thing I know that is important for us to discuss is sometimes we have people who come to us who have histories of things like sexual assault and things like that. And it makes these types of appointments very, very nerve wracking. What types of pieces of advice would you give in that type of situation?
I think if you can be honest and share that you've had those experiences, and that may be really hard to do, but we want to do what we can to get the information that we need, but we want to make it do it in a way that's not intimidating or upsetting or scary to you. And so, if I know somebody's had sexual trauma in some way or for whatever reason is really terrified about the exam, each of us, I'm sure, has our own ways that we do it. But I have the patient guide me and tell me what they're willing to let me do. And I always say, at any point that you want me to stop, you just let me know and I will stop. We do not need to continue this. And we'll try and find other ways to maybe get the information that we couldn't get before. Like if we can't do a vaginal scan, maybe we'll do an abdominal scan. But it's really helpful if you can let us know that, because then we can really gear your appointment and your exam to that information to make it more comfortable for you.
Mm-hmm. Episode 132, we actually talk about this a lot with Melissa Webb, who is a therapist who specifically deals with people with history of sexual trauma. So please know that all of us want nothing more than to make you feel comfortable and not to worsen trauma. The more you are comfortable telling us, really just this has happened in the past, we don't need to know any details whatsoever.
Mhm.
And particularly if you're okay with us leaving a note, like we all have the ability to write notes to staff to say, hey, history of trauma, go slow. History of trauma, say absolutely everything, and things that we do a lot for our patients just as a matter of course, but you're going to pay extra attention to when you know somebody's got that history.
Absolutely. All right. Well, I think we have covered a lot today
Mm.
about the new patient appointment, and I think this episode is about the length of a new patient appointment.
That's right.
Those are long appointments.
Yep.
Any other words of advice?
I think you can always gather information. I think, I always tell patients that when they come into the appointment, my job is to give you the information that you're seeking, but it's your choice in terms of whether or not you want to take me up on it. So if you are leave there and go, gosh, that's way too much. We're not ready for this. That's fine. I'm not trying to push anything on you. My job is to let you know kind of what the issues are and what needs to be tested. And then, it's your choice if you want to continue with the exams and the treatment.
Hmm. And typically all the testing that we do, even if you come in knowing, your OB did an HSG and you know that you've got blocked tubes, we're still going to order the rest of the testing because you can have more than one problem coexist at the same time. And if we don't know about it, we can't manage for it. And some of these problems can really very heavily change the direction that we go in. And so
Mhm.
even if we know exactly why you're not getting pregnant, we're still going to do that testing because
Mhm.
we want to know, is there anything else we have to consider? And so sometimes people feel like, oh, this is unnecessary. And in reality, we've all been burned by thinking we knew it
Right.
all, and then we didn't. And you make that mistake exactly once and never again.
Yeah. I mean, you're coming when you decide to make a step to go see a reproductive endocrinologist, you're really going to go see somebody who is going to leave no stone unturned, dot those I's, cross those T's. And we've all had those people who are like, "Oh, I don't want an evaluation. I just want you to give me Clomid." And that's not that's not good medicine for where we are at our level. And so, no, it's not that we're trying to withhold anything. We're making sure that we're not giving you Clomid and making sure that, he's shooting blanks or the tubes aren't blocked, because we've all seen those things happen and people have come to
Mhm.
us and it's like, oh my goodness, I've been doing this for a year. And it's like, well, that wasn't going to be working because we didn't have the whole evaluation. And so those circumstances are real. And what we're trying to do is help you get your baby as quickly and as safely as possible. All right. So, to our audience, thank you so much for listening and tune in next week for more. Also, be sure to subscribe and leave us a review. Would love to hear from you. We're on Instagram, Facebook, and YouTube. So, be sure to follow and subscribe and stay updated on all things infertility.
You can also visit fertilitydocs.uncensored.com to submit specific questions you have about infertility. All questions will be answered on the podcast anonymously in the Ask the Doc segment, so don't hold back. We'd love to hear episode ideas, so let us know what you're thinking and what you want to hear.
And as always, this podcast is intended for entertainment. It's not a substitute for medical advice from your own physician. All right, we'll talk with you soon. Bye.
Bye.